does, I mean, I'm happy.
Go ahead.
Okay. Well, one of them, I would like to just go over what session that I had. It's actually three sessions. One second. And then the other one is just to present another case that will be an addiction situation that I would love to hear what you would say about it. So the first one, it was actually three sessions. It's someone who's been coming to me for a long time, and we've had some rate of success. She's a very, very, very developed person. Um, she then had a very serious, like shock trauma at a birth of her daughter's terrible situation, and she was just not functional from it to the degree that she wanted to be. She was just constantly traumatized every time she thought about it. So she came in. We did three sessions, and I ended up working with also some other modalities, but basically uh, it was it was gone like by the end of almost the first section and second it was practically done. The third section there was one part of it that was left, like the main part, and that was finished within the third session, and she was just amazing, and it was finished with. And I at the time I also pendulated between there were two target memories from this trauma. um, there was one main target memory, yeah, that was the trauma. And then at some point, like this new vision, I would say, not like it wasn't even a cognition, but a vision of the baby. The baby was like in a terrible situation in the first part, in the trauma vision. And then the second one was just like this golden, almost ethereal image of this baby, this same baby. And so I actually pendulated between the two of them, and that finished it off so beautifully. And at the end of it, yeah, it's just like
ניסים
it wasn't even.
ונפלאות, ניסים ונפלאות של
It was
EMDR.
unbelievable. And I've heard from you, Dr. Goldwasser, about how like convulsing on the table. She was convulsing on that table. She was really, really like feeling that trauma, allowing that trauma to go through her body. Um, she was lying down. So I worked lying down with some of these things. And I also had her in the middle of a transforming touch situation where we used the EMDR as an enhancement. So her nervous system was in the process of being regulated while she was going through this. And it was just an unbelievable, beautiful process to see.
It's really quite awe-inspiring when you see um, the body release the trauma at a physical level.
Yeah.
I shared with Tova that I had a patient last week with a very similar severe birth trauma, gave 6.5 months to a frighteningly undeveloped child that ended up being autistic, and what she went through, and she was convulsing in my office. Her body was experiencing these uncontrollable spasms, and after she finished, she felt a sense of relief and being liberated from what was she was holding on that she had never experienced before. This is really very deep somatic work. Did you have a question about this, Tova, or you wanted to share?
So no, this I wanted to share. This is what I wanted to share. Then even toward the end of it, it was like going back to the traumatic one, there was a little bit of a convulse, and then going back to the beautiful one, it was calm. And just a little bit more of convulsion, like tiny bit, and then it was calm. And then when she went back to it, there was nothing. I went back to the other one, and that was it. We ended the session. So
It sometimes
yeah.
come in waves. Just it comes
Yeah.
in with yeah,
You
yeah,
mean later on it could come up again? Is that what you're saying?
and or not. Whatever
Or not?
whatever happens,
Okay.
whatever happens, happens.
Okay, we'll see, I guess.
Okay, kol
And
hakavod.
the other,
Yeah,
what?
kol hakavod. Good work.
Baruch Hashem from him. The other thing is, there's a girl who's started by me now who has she has addiction. She has porn addiction. She's a teenage girl,
Mhm.
and she also is addicted. Like, I don't know if this is the proper way to verbalize it, but she's addicted to an idea of marrying a certain boy who was her brother's friend, but now he's not from anymore, and she doesn't see how she can marry him, and it's really hard for her to forget about him. So the idea of marrying him is like stuck there. She
Fixation.
can't stop, as well as the porn addiction that movies, you know, it's a big one.
Well, first of all, you're talking two dynamics. One, there seems to be an obsessive fixation, and
Yes. Yeah.
you can use EMDR to help dissolve um, fixations like that when someone is stuck on something. Um,
Right.
and
You,
I'm sorry.
no, you mentioned, I remember once that there was something like that in when you taught us, and that you created a situation when there was disgust.
Well, that's what we're going to work on today in terms of the addiction.
Right.
Um, so, anyone else want to share before we train? Because this is a good segue to the addiction protocol. I sent it to you earlier so that you at least look it over, and if you have any questions or comments about it. But do you want to open up with questions or comments, or do you want to go over the protocol? Why don't we just go over the protocol? If you guys can take a look at it. So basically, the main difference is, well, there are a couple of things. Number one is, and this relates to Rafi's question about cigarette smoking. Um, so cigarettes, I found at least, let me get back here. I found in my experience at least, um, it's lavdavka. It's not necessarily true that everyone who has a cigarette addiction has trauma. A lot of times, nicotine is highly addictive. And a lot of times, they pick it up as teenagers and they just get physiologically addicted. There's no trauma. And sometimes it does alleviate anxiety without trauma, and sometimes there is trauma. So I think the first thing you have to evaluate is there trauma? Um, because you can't just assume that just because a person has addiction, there's trauma, especially when it comes to something that is so clearly physiologically addicting, such as cigarettes, that may or may not relate to any kind of underlying psychological issue. Well, um, you've treated somebody with cigarette addiction that just picked it up as a kid, and they just kept it going, and it just helped them to alleviate whatever anxiety or stress, but there's really no trauma. So the first thing is, yes, trauma. If there is yes trauma, then you do the protocol and you identify what trauma or traumas that may be underlying the addiction. My experience is that most other addictions, there is some underlying trauma that they're trying to anesthetize themselves when they're trying to um, deflect away from the pain that's associated with the trauma. And then because you want to first, you want to eliminate the source of the trauma and what feeds it. Now that doesn't always or even usually just wave away the addiction, because there's already these very strongly developed neurological pathways that have been developed. Just um, just, just dealing with the trauma itself does not necessarily um, mean that the addiction will go away. Although it has happened where I've worked with somebody where there's clearly a trauma and the addiction or a fetish that relates to the trauma. Once you're able to clear that trauma, the addiction dies down or can be eliminated. I would say that the majority of cases, the significant majority of cases, it does not, because of those neural pathways that have been developed. Um, so clear the trauma. And then once those traumas are cleared, then their neurological system is more ready and open to be to if we could try not to text while we're doing it, it's a little distracting for me. I guess what I think maybe AD is getting, I just get distracted. So if we can just try to keep the chats, unless there's a specific question. But even just that, we'll just ask them when we're done.
No, don't worry about it. Just tell them they have to
Okay, so once the traumas are clear, the nervous system is in a much more available position to be reprogrammed. Because if you don't clear the traumas, it's just going to keep coming back, because these addictions serve a purpose to anesthetize the traumas. If you desensitize them and reprocess the traumas and clear it from the nervous system, then and only then are you really able to tackle the addictive behavior. Does that make sense? Okay. All right. So once that happens, there is a significant difference in terms of how the protocol works. So in the standard protocol, you're at first assigning a negative cognition that's associated with trauma that has been developed as adaptive. And then you go through the protocol, and then once they're in the left brain, you ask them for a positive cognition that they can develop that's associated with it, so that when they go back to the trauma, you're actually trying to break down the old negative cognition, that old neural pathway, and build up a new positive neural pathway associated with this new positive cognition, right? With addiction, it's the opposite. It's the hefef. Because they have positive cognitions associated with the behavior. I feel free. I feel calm. It's a release for me. I don't feel the pain. They have positive cognitions. And those positive cognitions reinforce the behavior. I do X because of Y. Can you all hear that? So what you're trying to do is you're trying to desensitize the positive association with the addictive behavior. And you're trying to build a new neural pathway that associates with a negative cognition, a reason to stop the behavior. And we'll get to the aversion in a minute. But do you all understand the difference now with this protocol? We're trying to elucidate, trying to bring out what are the positive associations with this addictive behavior, and that's the target. And we're trying to build up a negative cognition instead that provides a deterrent cognitively that is associated with the addictive behavior. So instead of it being strongly associated with some kind of positive reward, positive outcome, we want to build up a negative cognition that's associated with the behavior. Make sense? Okay. So you go through, the same thing with the only difference also is with the feeling, the positive, when you're looking at the emotions, quite often they're positive emotions. They feel exhilarated, they feel calm, they feel relief, they feel excited, they feel thrilled. You're targeting the positive emotions. Yes, Pro.
Do you not think it's necessary to go into, I'm doing it because I don't want to feel. I don't want to feel bored, lonely, anxious.
Yes. By the way, Pearl, you're a very interesting but somewhat unknown statistic or a data from research. What do you think is the number one emotional state that is associated with addictive behavior? Anyone?
Loneliness.
Lonely. I was also
Close, but no cigar. I know most people wouldn't guess this.
not boredom, surely.
Yes, Pearl. Boredom. They don't know what to do with themselves, so they act out. Surprising, no? That is the number one trigger for acting out. They're bored. So Pearl, you're right. But that still fits into this protocol. I do X because I'm bored. It still fits. I have nothing else to do. It still fits in the protocol. Okay, so so if a person's, I do this because I'm bored and it helps. So when they're in the image, what kind of emotion will come up? Excited, thrilled, active. So you're actually targeting positive emotions that are associated with addictive behavior. So that's another difference. And also where they feel in the body, it's pretty much the same thing. And then you start the rapid eye movement and prompt them to get into the left brain and say, so once you're in your left brain, your rational brain, where the reality-based processing comes in, what are the negative consequences, or what negative thoughts come up when you think about the behavior and you're in that image? And then they will talk some of the consequences. Then they can start testing that, but usually only until they're in their left brain, when they can think rationally. Okay, so once we've done that, which is, it's similar to the protocol, except we've reversed the dynamics. So the next thing comes from behavioral therapy, operant conditioning. It's called aversive counter conditioning. Instead of them being conditioned to the behavior because of the positive associations and positive consequences of how they feel while they're doing it, you want them to imagine the same behavior, but in an image that's disgusting to them, that's aversive, and it's got to be really strong, the strongest possible. That's why aversive counter conditioning, because you want to create because their neural are super strong in associating the behavior with a positive emotion, a positive feeling, a positive situation. That's why they keep acting out, because they have this very strongly conditioned association. The aversive counter conditioning means we build up a new neural pathway that is connected to something that's highly aversive.
Can you give an example?
Yes. So I work with men that have sex addiction issues, and it's not easy to treat. It's not easy to change that behavior because the dopamine rush is so strong, and really almost all of these men, and I've worked with some women, are in a lot of pain. The pain is very deep, and this is the only they know how to, in essence, stop pain. So I am to come up with something aversive, and I don't want to get graphic, but quite often they come up with sexual situations where there's poor hygiene, there's feces, they imagine sexual transmitted disease, they come up with someone that's very ugly to them, someone that's disgusting, and they use that as the image, and it's very effective. It's very powerful, because and the more they do it, the more they strengthen that new image. The first image dies down, and that aversive image gets stronger and stronger. So the goal is that when they think about acting out, instead of going to positive image and the positive feelings associated with the dopamine rush, they are associating this addictive behavior with this aversive image. And one thing that I didn't mention in the protocol that I sent you, which I just realized, is you also want to tap into what emotions are associated with this new aversive image. And sometimes it's highly physical. They feel nauseous. They feel tension in different parts of their body. So you want to tap into the negative emotions and also the body's sensations that are associated with, and you want to build those up. So the goal is to diminish the positive emotions and the physical sensations, which are often stimulating, positive. You want to diminish that and build up the negative associations, the negative emotions and the body sensations associated with this new image. And then you want to ask them what words go best with a negative belief about this behavior, this experience. And they'll come up with some really good things once they're in the left brain. This is killing me. This is destroying my marriage. I'm out of control. I don't want to be doing this. This is not who I am. This conflicts with everything I stand for. It conflicts with my values. I'm going to get in trouble with the law. There's a whole list of them which they don't allow themselves to access because the positive association and the urge is too strong. So once you diminish the urge and you shift them into the left brain and start focusing on the negative image, then they can start accessing a different neural pathway, what the negative consequences are and what are the negative feelings and beliefs about it. Because otherwise they just can't, because the positives are too strong. And then you use the bilateral stimulation to instill or install those new neural pathways, the negative cognitions, the body sensations associated with this new negative image. So you're basically changing a neural pathway, many neural pathways. You're changing the imagery that's associated with the behavior. You're changing the cognition that's associated with it from something positive to negative. You're shifting the emotions away from the rush and the good feeling of anticipation of using or acting out, and replacing it with the negative emotions, shame, guilt, fear, and also installing the expectation of having a negative body sensation because it's now associated with something. So the goal, when you know that you've completed it, is when the positive cognition, and you do the 0 to 10, has gone down as close to 0 as possible. The positive emotions come down as close to 0 as possible. The excited body sensations go down as close to 0 as possible. And the negative cognition is as close to 10 as possible. The new negative emotions are as close to 10 as possible. And the disturbing body sensations are as close to 10 as possible. So with that, it's a lot of information all at once. So comments, questions?
Number one, when are you dealing with the trauma and when are you dealing with the, with the addiction? I didn't get that. I mean, are you first dealing with the trauma and then with addiction?
Yes. The trauma comes first because that's what feeds it. So the first thing is just protocol, what we taught, what we learned. Just do a trauma history, see what's there, and target it. And Rafi, you're right. This is not a one-shot deal. This is a process. I mean, you may take one session or several sessions just to clear all the traumas. I mean, how often do you have somebody with one discrete trauma that develops an addiction? Sometimes, but not often. Usually there are quite a number of them that are feeding this. So you have to do that first. And then once the traumas are cleared and they can tell emotionally and physically, visually that has been desensitized and cleared, then you shift into the addiction, the focus on addiction. Is that clear, everybody? Okay. Next question. Comment. Take it all in. It's a lot.
So you could do that with foods, food cravings and things like that.
Totally.
It
really applies to pretty much every addiction, with the only exception, again, is that with cigarette smoking, there may not be a trauma. I mean, have you ever experienced a significant addiction with no trauma associated with it? It's very, very, very rare. Very, very rare. I mean, it's like when there's smoke, there's fire. You know, if there's an addiction, there's usually trauma, except with cigarette smoking. So you just have to, you can't assume. But, you know, I mean, there is it possible. You know, the only other, like Pearl, you mentioned about eating. I'd say 90% of people who eat compulsively, there's something there. I can imagine where there's someone who overeats, maybe not for emotional reasons, not because of trauma, but they're just eat too much. They enjoy food and they're gaining weight and they want to stop. They can't. So again, just make sure that you're not assuming that everyone is carrying a trauma that they're trying to anesthetize. But definitely compulsive eating. Now, the only thing, you know, not every eating disorder is an addiction. You know, that's like, you know, anorexia, is that an addiction? Maybe addiction to, you know, perfectionism. It's really more related to OCD and, you know, more of body dysmorphic disorder, BDD. I don't know if I would call it addiction. So not every eating disorder fits this model, but certainly compulsive eating, overeating fits. Good question. Next question.
I was just going to add that it's very similar to the swish technique in NLP, as far as I know. It's
Can
one
you-
of the well-known techniques in NLP, which I trained in years and years ago. But it was a very similar idea to
Yeah.
imagine it like that.
Yeah.
It's good.
The only difference is that we add the bilateral stimulation that can help break down the old neural pathways that feed and reinforce the behavior, and it builds up new neural pathways that can help a person literally rewiring the brain so that the associations have changed. So that's the difference between this and NLP.
I have a question. So with food addiction or sex addiction or other ones, so I'm saying food or that because in a way when it's balanced, it's fine. Like I didn't say drug because of that. Like there's
Sharon, we're having a hard time understanding you.
no, I got a phone call. That's why I got cut off. I hung up with them. So what I was trying to say is that there are certain addictions, like food addictions, that if you would go to the opposite way and you would try to get a really negative aversion, you don't really want to do that with food. Like you want to get it balanced, not like the opposite, not like, and even like a sex addiction, you want them to be balanced or her, whatever. Like you don't want them
Yeah. So
not.
yeah. So Sharon, you're highlighting an important point in Michlal and about addictions. There is a fundamental difference between behavior that is eliminated, like drug, gambling, where the goal is zero behavior, versus sex and food, which is a natural and healthy life affirming behavior within certain parameters. So in terms of sex addiction, most people act out in a way that is not affirming. It's really very damaging. So you want to create an aversive image and an aversive association with that specific behavior, but not sex in general. The same thing with food. You know, there's certain, like for people that are very obese and they keep eating or drink, you know, there's certain foods that can be targeted that are unhealthy, that they crave, like high sugar content, high fat content, and create, like if they crave like ridiculously hard cakes or sodas, so to create an aversive counter conditioning with those foods that are targeted for elimination, but not eating in general. Make sense? Okay. Good question.
Can I make a comment about the food addiction thingy?
You don't have to ask, you just comment.
Okay. I have discovered in the last like year and a half through my own experiences that, I mean, in terms of my own life, I tried to look at with my obesity, is there traumas? What's eating me? What's causing this? Blah, blah, blah. But I was a skinny kid until I hit puberty. I now discovered that I have a condition called lipedema where all of a sudden you gain all this weight during puberty, during pregnancy, and during menopause. And then I discovered this diet that has now been healing me, has gotten me out of bed and everything else. And I didn't have, and I even looked at my through this, and the only thing was basically that the food is made, especially in the United States, to be addicting. I mean, all the processed food is specifically created to make you eat. So I don't think that every time that someone's obese or metabolically unhealthy, that it's coming from a psychological thing. Even though, I mean, I looked and I tried to find all sorts of what could be causing what trauma is causing. Not that I don't have traumas, but that did not cause this.
So you're affirming the point that I made to Pearl's question. And that is that, like smoking, eating, it's not necessarily trauma induced. It's not necessarily related to trauma. You know, there's some people that have metabolic conditions that cause obesity. It has nothing to do with trauma. That's why you have to do a careful assessment at first. You know, is there actually, you know, Sippy, you're bringing up a very important point. There's really two steps to the assessment process. Is there trauma? And number two, is the behavior related to the trauma?
Right.
There may be trauma that's not related to the addiction.
Right. I have plenty of trauma that's not related
to
that.
To the addiction, exactly. Because and number three is that just because you're obese doesn't mean you have a food addiction or an eating disorder. It could be strictly metabolic.
Right.
So very, very important points. Yes, Susan.
I was just going to raise exactly the same thing that Sippy did, because I have food allergies and food intolerances, which until I discovered what the problem was, I was addicted to those foods. So exactly as you just said, I couldn't get enough of the sugar, I couldn't get enough of the chocolate, had no idea why, but all I knew is I was ill. And then once I started to come away from those foods, my body calmed down, I lost tons of weight. I haven't got an addiction. My addiction's gone in a way because it wasn't a real addiction. It was my body being addicted, because that's what happens when certain foods don't agree with you. Your body craves them naturally. Once you eliminate those from your diet, then the craving goes away. So I was going to raise exactly that point. It's not necessarily trauma enforced at all. You've got to be very careful.
You're highlighting the importance of doing a careful assessment. Careful interview. What's going on here? You can't just jump into treatment without really assessing what is going on here. What are there traumas? Are the traumas related to this? And this is really mostly, again, smoking and eating. The most other, at least my experience has been that the other addictions, drug, alcohol, sex, gambling, they're escaping from some underlying pain.
Yeah.
Now, the only other thing I would say about gambling, the majority of people that I work with who have gambling addictions have trauma, and when they're in that casino or they're online, they're in that zone and they don't feel pain. I have seen, similar to the cigarette smoking, when people just discovered gambling and they may have a certain predisposition towards thrill-seeking behavior. And they may not have trauma, but it just got a hold of them. You know, they just, the whole scene of being in the casino. And actually, now that I'm thinking about it, this is an interesting case. I had an older man, 70s, been gambling for decades, and his wife schlepped him in because he had been kicked out of several, because there's a lot of casinos in South Florida. And he got kicked out of one after another, and she was saying, Adkan, you know, you need to help, you're out of control. He didn't really have traumas, He was a narcissist. He was of the type that wasn't abused or neglected. He was the prince. He was treated like a semi-god by his parents. He was the only son, and he had a tremendous sense of entitlement. But what he was addicted to was the attention that he got because they knew that he was a high roller. He was very wealthy. And he would drop a lot of money and he'd get a lot of attention when he walked in. So it was feeding the narcissism. Was there trauma? Not really. Not really. So that just shows how important it is to not assume there's trauma, but it doesn't mean that you can't use the EMDR. Because remember, EMDR is based on a desensitization paradigm. You want to desensitize what's desensitized. And addictions they're very sensitized. It really triggers people. They have significant urges, obsessions, compulsions that are associated with it. So you can still use EMDR to desensitize and reprocess it without the trauma. So that's why when you have somebody who comes to you with an addictive behavior, really do a careful assessment. Is there trauma? Don't assume. And is the trauma associated with the behavior?
What about people who have, let's say, had severe pain, injury, whatever, and were prescribed opioids, and then obviously there is a secondary thing, because once they start taking it, then there is a feeling that they get from it. Okay, but then they may have trouble getting off of it afterwards, and
Yes.
again, they may not have a trauma, but it could be that they then have to deal with.
So Sibi, that's an excellent example of an addiction that isn't related to what we consider a classic trauma. However, would you consider pain as being somewhat traumatic?
Yes.
Yeah.
I would think so.
Yeah. Okay. Yeah.
Where's the pain coming from? So you can use creatively EMDR to help identify the pain and the positive feelings associated with the use of the narcotic, and then do the protocol.
Okay.
I don't feel the pain. I feel free. I feel in control, but they're out of control.
Yeah.
I've worked with a number of people who, the doctors have no problem prescribing OxyContin. Do you have OxyContin in Israel?
They have the I don't know. It's Percocet with the.
OxyContin is extremely, and they're giving them out like candy for anybody who has pain. It's
They
disgusting.
use tramadol also here in Israel.
The tramadol is not as addictive as OxyContin.
Right.
Not even close. Not even close. I mean, tramadol for pain is actually not so bad, but OxyContin, you can get addicted very.
No. But when I was in severe pain, and I'm talking about like complete body pain, they had me on fentanyl patches and Percocets and gabapentin, and
so you can get very addicted to these highly addictive drugs. And but thank you for bringing this up, Tippy. That's a very important.
because I didn't like the feeling, so I didn't become addicted, and I was able to quit it right away.
But anyone who has an addictive predisposition, they love the high. You get very high on this stuff.
Yeah.
It's really a double barrel problem.
Yeah.
You are relieved of the pain that is causing you such stress, and on top of that, you're also experiencing a high if you're predisposed towards it. Not everybody likes the feeling of being high.
Right.
But for those who do, you've got a double barrel problem.
Right.
It's the relief and the high.
Right.
That's why it makes it's much more difficult to treat this. But you can use the protocol for things like that, where a person gets addicted without any real trauma.
But please forgive me for my ignorance, but what about medical cannabis? Is that not a similar thing? Because that's prescribed. I know it's safer than buying cannabis off the streets and everything, but people do come to rely on that. It is an addiction to having it, because without it, they're not functional.
I think it's the same. It's the same dynamic. Not everyone who uses marijuana has trauma. Many do. Many see the medical cannabis route to get high.
Yeah.
Because of whatever underlying pain. And some, like, have a close friend who has a severe spine pathology, and she's in chronic pain, and she uses cannabis on a daily basis. It helps her. She is probably had the most idyllic childhood, great marriage, no addiction personality, but she uses it every day. In her case, she's okay with it because it's a solution. So, that's another example of, is she addicted to it? Yeah. Is that a clinical problem? Not necessarily. For her, it's a solution. And she's a straight person. She's a very high level person who sees this as a way of managing chronic pain because she desperately doesn't want to have surgery. So is that an addiction? By the way, there is a difference between dependency and addiction. She is drug dependent. I wouldn't call her an addict. It's not something that's out of control. She controls it. She uses it within certain limits. I don't think it's interesting. Any thoughts on where dependency stops and addiction starts, or the difference? Anyone?
I would say causing interference in your daily life.
Very fine line. I think it's a line that's very hard for people to even begin to recognize. I know somebody who's on medical cannabis, and by the end of the day, they're so high that they can't even put their words together. But he can't stop that because it's prescribed. It's different. It's a different set feeling. It's a prescription that's safer.
Right. So, but that's cannabis abuse.
Yeah.
People do use cannabis in a very controlled way where they're not looking for the high, they're looking for the pain relief. This woman doesn't get high.
Right.
She has it's a fairly low, she's titrated. She knows exactly what dose helps with the pain, but she's not interested in getting high. She's a very high level person, and she can't afford to be cognitively impaired. But that's an example of using, and your example is misusing it.
That's the line. That's the answer to your question. Like when you still have the
dependency
you're
versus
still able to make the choice, when you're still in control of it.
That's a very good point, Sharon. That's a very good point. So she's drug dependent, but she's not addicted because she can control it. She's very careful about titrating. She's not looking for the high, but she is dependent on it for pain relief. So is that an addiction? Not really, not necessarily. But what you said, Susan, he's addicted. Good conversation.
And also when you're treating somebody that, let's just say, has an addiction, whatever it is. So there's two different. There's either to get rid of an addiction and to get them to lower themselves down to this woman's level of just getting relief, or you're treating somebody who doesn't even need the relief anymore because they don't have that, like they recovered, let's just say, whatever it is. You want to realize, you want to desensitize them, like, and make them realize, okay, that was in the past that you needed the relief. I don't know how exactly to do that in the protocol, but there's a distinction between somebody that still needs the drug, but wanting to get them in control of it.
Yeah. Well, there's another point to this discussion I think needs to be dealt with.
Very complicated.
I think you have to evaluate let's talk about substance abuse, or substance use rather. Is it dependency or is it addiction? And as I think Sippy said, if it's an addiction, is it a problem? Is it affecting a person's functioning? It is possible that a person can have some kind of addiction that started with a medical use, and they are addicted, but they don't have a problem. They're not married. They're single, and you have to be careful to make sure that you're not challenging something that they don't see to be a problem, and it's not affecting their lives. It's not affecting relationships. You have to kind of have like an operational definition of addiction that needs to be treated versus addiction that maybe has been incorporated into their lifestyle. Because if you push it, You may lose the client because he's coming for something else. Does that make sense? So these are all issues that have to be really dealt with and evaluated carefully. Next question.
So basically, you're saying that addiction in and of itself is not necessarily something that we need to not want if it's working for us.
I'm sorry, and then
And
not
not
want? Say not want?
right, to not want. In other words, if it's not it's not ruining a person's life, affecting their relationships in a negative way, and they're addicted. They were saying that addiction in and of itself is
Yes, yeah.
maladaptive in that situation.
Some
give
people
you
are
a-
addicted to Tylenol.
I'll give you a good clinical example. I'm working with someone who smokes marijuana every day. It's not medical. There's no medical reason. He's been smoking marijuana for decades. It's part of his lifestyle. He came to me for a totally unrelated problem. It's really unrelated. He's a high functioning addict. He's got an issue with an abusive boss. But he's been smoking marijuana for decades, since he was a teenager. It's really, I mean, I think he's telling the truth. It doesn't affect it. He does it at night. It doesn't affect him during the day. This is what his routine has been. He comes home and he smokes, watches TV, goes to sleep, and wakes up, and he's able to function. And he's a high level person. He's in the real estate business, and the owner of the real estate brokerage firm is a narcissist and very abusive. And this is a very nice person. Do I target the marijuana use? No.
No.
I didn't touch it.
Got it.
Why not though? Ask the question.
Mhm.
Answer the question. Why don't I touch it?
He's using it to cope.
I would.
It's not interfering in his activities of daily living.
It's not interfering with his function. It's
Not his relationships.
no.
It's even more than that. I think that I would just start from what he's bringing and what does bother him.
That's right.
You never know where it'll lead. It might actually one day lead to him going there exactly to that point, to the marijuana.
So Sharon's moving into the direction where I wanted to go with this question. What kind of effect? You're a client, you're a patient, comes in with a situational issue that he needs help with, that you need help with, and you happen to smoke marijuana at night, and it's not a problem for you, it's not a problem for your wife, it's not, it's just something you do at night, and you zero in on the marijuana, and the therapist zeroes in on the marijuana. What does that feel like for you?
That feels like an invasion of something I don't want to talk about, because I've come for another reason. I'm quite happy with my marijuana usage. My wife is, and it's not something I've come to talk about.
Okay, good. What else? What else does it feel?
Invalidated.
Invalidated? Okay, good. What else?
Not respectful.
Could you even say judgment? Like they're judging for the marijuana?
Yes.
It feels like transference.
I'm sorry?
What's the agenda?
It feels like transference.
Transference. Yeah. Wait, can you speak a little more about that?
Yeah, it looks like the caregiver has a problem with it, and somehow they transfer it towards the.
Yeah, so it's more like counter-transference, that it's more the therapist's problem than.
Yes.
Yeah, very good. So I'll tell you I'll tell you the word that I would use to describe that: misattunement. They're attuned.
Yeah.
They're
Having
not.
an agenda. Having an
They're
agenda.
not attuned to what I'm coming in because I'm having a real stressful situation in my workplace, and I'm coming for help to how to cope with that. And you're talking about my marijuana use, which is, I've been doing this for decades. I feel that the therapist is misattuned. They're on a different wavelength from me. They're not attuned to what I am struggling with.
Yeah.
And he's creating a problem that's not a problem for me. Yeah. And I'm not in denial. I'm not being defensive. It just happens to be what I do, and it's never been it's managed. I do it every night. I've been doing it for decades. That's not why I'm here. I mean, that would be a real turnoff for me. So that's why it's also very important. So there's really 3 levels here. If they come in because they're addicted and they need to work on it, okay, you've got a full green light. If they come in and they're struggling and they're part of the problem, but they're not ready to do the yellow light. But if they have an addiction and has nothing to do why they're coming, that's a red light. Make sense? Okay. Well, this was a lively discussion. Before we finish, I just for those of you who joined in late, we're going to be doing another EMDR training September
14th and 15th.
September 14th and 15th. I'm bringing this up for 2 reasons. Number one is that I've been asked if anybody who's already been trained can come back for a refresher, and the answer is yes, if you want to do it, and we will only charge you half the price because you've already done it. So if you want to sign up, with pleasure. Number 2, once we get the announcement on this chat, we would really appreciate it that if you could put it out to every chat you're on, or to send it to colleagues that you know may be interested in getting trained. Because we're really, I mean, you see how tonight there's 14 people on the I've trained quite a number more. I wish they were on this chat, but they decided not to. But if each one of you is treating 5 or 10 people, that's 150 people that are being relieved of trauma. And if we keep doing this exponentially, you'll see the number of people that are actually getting relief from their pain. Yes, Pearl.
But I have 2 questions. One is a quick one, is if one can just come on the second day and not the first day. And the other question is, do you remember towards the end that Susan wrote this whole list of things that we wanted to address?
We're on it. We're on it.
Okay, so will that be included?
Oh, that's why we did it. Yeah.
Yeah, okay.
No, I've already reminded her. She's collating that, and it's going to be part of the new training.
That'll be part of that. So if we can only come maybe on the second day, is that a possibility? Or
As far as I'm concerned, Susan, what you think, but I think if you've already gone through the training, I'm certainly a lot more flexible about that than, like there's somebody who from the States who can only come for the first half of the first day, and we're trying to come up with solutions of how to make it up because they need really to have that training. But she literally can't. She's got a wedding that night. But for you guys, I think we can be flexible.
Can we get the corrections to the protocol that list of things, even if we can't come to that training? Just because, first of all, I'm not in the country.
Yeah, I'm not going to be in the country during that time.
Okay, Susan, you and I need to work on that.
I sent you everything that I had, but we can go through it. We need to sit down and go.
Yeah, I need to go through it with you. Yeah. Okay. All right. Well, how do you all feel about today's session?
Excellent.
Good.
Excellent.
Thank you so much.
Great, thank you.
Just
If you do
Dr.
have,
Goldwasser,
yes.
about the obsessive fixation that I mentioned in the beginning about the boy, I would treat it the same way as try to get her to be disgusted by him way.
I've actually done that. I've done that. People are fixated, and to imagine something about him that's subversive. That's disgusting.
Is that what you would do with this?
That's what I've done.
Okay. Thank you.
Bad breath, bad teeth,
Yeah.
bad hygiene.
Yeah.
Find out that he's into something that's disgusting, like anything, to just to break down that neural pathway that's associated with the fixation, because she's probably over idolized him, and you want to be able to create a new neural pathway that's aversive, and when it works, it's amazing. So I would love for you this month to try it if anybody has somebody who's dealing with addiction, and come back next month. And also, by the way, a few of you have reached out to me for individual help. I'm happy to do whatever I can, either text or through a quick phone call. Use me. I'm before 8 o'clock. I'm in the morning. I was going to say I'm looking for something to do. That's not necessarily true, but I am available, and use me. That's what I'm here for. Okay.
want to get it?
Before 8 in the morning for you. That's what you mean? Like your
Yeah,
time?
yeah, like 2 to 3 in the afternoon.
Mhm.
This is my best time for free consultation. I wish you all an easy fast if you're going to be fasting next week, and hopefully this will be a meaningful fast and a meaningful experience given everything that's happened. I think that's part of the reason why everything's happened, that kind of brings us to a different level of consciousness.
We need to get the date from Fort. Do you want to do the next date for the entry for the diary for the next supervision meeting?
Yeah,
I
yeah.
get that as the 24th of August, 4 weeks today.
Good with that.
Is that okay for everybody else? The 24th of August at 5 p.m. is right.
Yeah. Yeah.
Yeah, sounds good.
Got it. Okay. Have a good
Thank
evening.
you so much.
Thank you.
Thank you. Thank you.
Thank you.
Pleasure. Good one.
Thank you so
Nice to
much.
see all
Thank
these
you.
tools
Bye,
again. Britt,
Bye.
next time you open your camera so I can say hello to you. I don't know if she's still there. All right, bye.